local public health units. So hats off to you guys for being innovative and recognizing the need of where the one program can help guide and assist our local public health units. Right now, our pharmacies across the state are conducting approximately 800 screenings. So 800 people per month are being screened for the risk of overdose and misuse. We also have a program that was started in order to help reach additional clients across the state that are receiving care in their homes. So we have 8 local public health units that are using a medication safety and opioid risk program for all of their clients in their home care programs. Those 8 local public health units receive all of the education and materials from us, and new this year, we'll be able to do all of the SOR reporting for that initiative, which I know Amy will talk about soon. And from that program, other local public health units then said, gosh, this is a wonderful program. How can we further reach more patients or clients? So we now have a pilot going with Walsh County in their jail and prison program. So their local public health unit nurse is providing, you can see in the image on the bottom left here, a discharge packet, essentially for people who are incarcerated. They're receiving a daily pill organizer, Datera, Narcan, and then education on overdose risk and misuse. We also brought or helped to bring DisposeRx to the state. And so instead of in addition to the large bags that Datera provides, we were recognizing that the shipping costs of some of those to some of our partners were quite high. And DisposeRx produces kind of a packet of Kool-Aid, essentially, that forms a gel inside the actual pill bottle. So bringing education and distribution to our state is where we are hopeful to help. We also have a new campaign called Dare, not campaign, but initiative with our pharmacies called Dare to Discuss. Over the 5 years, we've recognized that our pharmacists are maybe not trained or comfortable talking about the sensitive topic of the risk of overdose, or excuse me, the risk of misuse and potentially addiction or substance use disorder. So we've created some educational tools and videos to bring that content to our pharmacists based on the data that we've collected. Brand new this year, we have a new university opioid safety program that we're launching. We are going to be reaching out to, starting with North Dakota State University and bringing it statewide through the North Dakota University system, hopefully, is education to that age range that is so in need of our help regarding this topic. We will be bringing education, stigma reduction, and then in the upper right-hand corner picture, you can see what we call a nalox box. So our program there is called Be the One. And these naloxone rescue kits will be placed in community areas like fraternity and sorority homes, the university library, gathering spaces, housing access. So they'll be placed right by the AED. And these kits are amazing, you guys. They include the 2 doses of nasal Narcan, alcohol swabs, and gloves. And then when you open the box, it actually starts a video and it walks the person through, okay, take a deep breath. Now come to the box and grab this. So it's exactly like an AED. And so we want to offer up the opportunity. We have access to these boxes and can get them for you if needed. So let us know if that's something that your community could find helpful. 2 more things, I'm sorry. We will be doing an environmental scan with across the state. We did this a couple of years ago, and DHHS let us know that the information we gathered regarding who's prescribing treatments for MOUD, how far are patients traveling, where are their openings, are there any full schedules, that was really advantageous. So we'll be partnering with DHHS to say, what kind of questions do we need to ask? And then we'll be doing that work and providing that information to the state. And last but not least, our PharmD program curriculum, of course, includes for pharmacy students education on what an opioid is, but we want to take that to the next level. What are preventative efforts? What are palliative care best practices? How can we train our future generations of healthcare providers to come out with prevention and misuse education that are at the top of their license? So we'll be piloting some of those initiatives in the pharmacy program and then looking to expand that to other health professions. So I want you to know that the One program is here to catalyze any ideas you have, offer any support that you need for any of these programs. If you have a home health program and you'd like to hear more about it, we can meet to discuss that. If you have a jail and prison program and you'd like to talk a little more about that, reach out. If you have an initiative to increase naloxone access in your unit, in your area, and you might not have, or you have other ideas, but maybe a naloxone box would be something in your local bar or your local library, please reach out. Our primary initiative is to help our local public health units and our SOR grantees in order to further your impact and meet and exceed your goals. So I did include my contact information there. If you have any opportunities that you would like help designing, education, anything like that, we're here to help.
Thank you, Heidi. We really look forward to continuing to partner with the One program and all the great work that you guys do. Moving on to some other statewide efforts that we're doing here, in relation to goal number 2 of reducing harm, we will continue to purchase naloxone. And then we will be able to identify some gaps in naloxone distribution. So if there's areas that aren't receiving some distribution, how can we address that and decrease that barrier there? We also will be doing some training on recognizing opioid overdose and appropriate use of naloxone. Our main training is at kind of those peer support specialist certification events, care coordination training. But if there's other needs, always feel free to reach out to us, and we do some training here too. We will purchase fentanyl test strips for syringe service programs if that's identified as something that you guys need. We have the ability to purchase those too. James, I'll let you talk a little bit more about the treatment side and what we're doing here at the statewide level.
Yeah, and I did just throw in the chat just a reminder that the quickest way, if you would like to request any Narcan, Disposarex, Deterra bags, would be to contact our main email that is always monitored by someone. Oh, our slides just went down. Thanks.
Oh, there we go.
Yep.
Better.
So,
okay, thanks.
Feel free to reach out to any of our team members. We'll make sure to get any requests you have ordered. Other than that, yeah, feel free to reach out to our main email for the quickest responses. So we are primarily partnering with the Department of Corrections and providing them with funding to continue to provide medications for opioid use disorder to individuals who are at one of the penitentiaries or Department of Corrections settings. And then we are going to look at how we can expand to help with those transitions from when individuals leave an incarceration setting and return to their community to make sure they have that opportunity to continue their medications for an opioid use disorder and get connected to the care they need. So that is something that a program we have not developed yet, but that is what we see as the next step for that Department of Corrections MOUD program. And then we also have a goal to increase the capacity of treatment providers in the state to provide contingency management. We are actually, if you want to go to the next slide, Amy, SAMHSA is requiring states to certify providers as approved contingency management providers for this SOR grant. So this is something that is new. They are outlining, and I just listed this out, not trying to overwhelm you, but to let you know what SAMHSA is doing this grant year. They're requiring that us as a state make sure any contingency management providers are trained in the following areas and that we certify they have been trained in these areas. We have to submit a plan to SAMHSA in December on how we are planning to do that. So I just want to keep you in the loop that this is something we are going to have to work towards. We have already met with the Addiction Technology Transfer Center for our region, as well as the Opioid Response Network, to see if this is something they could assist with. They have identified that they could develop a training that would meet all of these SAMHSA requirements. So just want to keep you updated that this is something we will have to require for anyone who is looking to implement contingency management. So we will just. Question? Oh yeah, go ahead.
So if we're not like the treatment provider, but putting in for the grant, would then we have to take that training also then? Or are you just like having one treatment provider within the scope get training, or are there others that can fall under that?
Yeah, so any treatment provider that would want to implement contingency management with our SOR funding would have to complete the training. So it wouldn't be on you, the local public health unit, but it would be for a treatment provider that you would want to provide funding to.
Oh, I see what you're saying. Okay.
Yep.
Right.
And so our hope, yep, you're welcome.
So
Timmy.
we have like outpatients, so would that include those then?
Only if they're doing contingency management.
Okay.
Which is an evidence-based treatment practice. Okay. So only if they're doing contingency management. And so our hope is that we will develop or have the ATTC develop a training that we could direct you to so that you could have those treatment providers watch this training. We would verify they completed it and then indicate they have been trained in all of these things. So that's our hope for the next couple of months of how this will play out. I do see one other hand is up.
Yes, this is Karen from Southwestern District Health Unit. You know, we already are doing this with our community program, you know, in conjunction with corrections. And so my question is twofold, I guess. Is this training going to be quite intensive, or is it going to be pretty user friendly and, you know, time wise, will it be, you know, something that's doable? And then the second would be, do I need to stop, you know, doing this until this is all approved, or do we continue doing this because we've already started doing this?
Yep, great questions, Karen. So first of all, don't stop what you're doing currently. Until I would rather we at the state get hand slapped for letting something happen until we submit our plan to SAMHSA and get that approved. I think it's okay for you to continue doing what you're doing, and we will communicate with you as soon as we're able to about how our plan specifically looks and what kind of training we need the providers to go through. As far as the specifics, I don't envision this being like, you know, multi-day commitment. I would see this as being maybe a few webinars that are, you know, an hour in length and maybe a 3-part series or something along those lines. So that's just me giving you a ballpark guess. I don't think it'll be a huge time commitment.
Okay, great. So in other words, we'll just ask for forgiveness later, not permission, but forgiveness. Got it.
You got it. Yes. And like I said, if you hear anything other from, we'll contact you if we say there's a need to stop or anything like that. But I would rather have the providers keep doing what they're doing, and then we will bring them up to speed with the training when we have something available.
Wonderful. Thank you.
Okay. Thanks, Karen. And then I think
do you have more, James?
No, there should be one more slide on the treatment side, and that is just oh, I think we lost it, Amy.
I see that. Sorry, guys. I don't know what keeps happening. It just shuts off. Okay, we're back.
Yep. And so I think the last slide is just that Department of Corrections. And so this is where individuals are able to receive buprenorphine prior to leaving the penitentiary setting. And so typically it's about 90 days before their release and they start the medication. And like I said, kind of our next step in this is we want to make sure there's that nice smooth transition once they leave the correctional setting and go back to the community to ensure that they're still receiving all the support they need and continuing to receive that medication.
All right, our last kind of set of efforts here at the state level align with goal number 4 of increasing access to recovery support services. And we plan to do that by integrating the peer support into crisis and emergency department settings like James had talked about earlier. We're already doing that as a pilot program with Sanford Health in Fargo. So we want to kind of expand that and see how we can expand that with our SOR funding. So now we're going to talk about what communities are doing, what the funded local public health units are doing, and some of the great work that's happening at a local level in North Dakota here. So our community implementation grantees, so those 21 local public health units, are implementing some required activities, and those include completing an naloxone assessment. And we're hoping to have a template out by the end of the week for you guys to start working on that assessment and then being able to determine where naloxone dissemination will happen throughout the next year, either continuing those efforts or recognizing areas that dissemination is not happening and how we can work towards getting naloxone into the hands of people that need it. Local public health units will also be doing training on recognizing of opioid use, of opioid overdose and the use of naloxone, collaborating with local pharmacies to bring awareness of the ONE program if they're not already participating in the ONE program, and then partnering with us here at the Behavioral Health Division to bring awareness of that contingency management training when we have that available, and some things put together for you guys to provide to local treatment providers. And then lastly, collaborating with all SOR grantees to keep enhancing efforts and preventing duplication of efforts. So in addition to some of the required activities, there'll also be optional activities that I'll share that grantees are implementing. But first I want to talk about the naloxone saturation needs. So this is kind of a formulation put together to determine how many kits are needed in each local public health region to ensure that in 90% of the time an overdose occurs, that there'll be naloxone available. So this chart right here identifies the 21 funded local public health units and how many kits your region will need to distribute throughout the next year to ensure that majority of overdoses that occur have naloxone available.
And if these numbers, you know, if you see this and you think, wow, there's no way I can get this much out in my community, please talk to us. Let us know if you do have concerns. This is broken down from a formula that SAMHSA had developed and gave to us as a state. And then we broke this down into county populations and then crosswalk this with the service areas of each of the public health units. And so that's where this number comes from. So, you know, I think it's exciting to have some kind of goal to know what we should work towards. But again, if there's any anxiety, concerns, please reach out and talk to us about that. And I do see, looks like Karen and Heidi have their hands up. So Karen, do you want to go first? I can't tell who did first.
Okay. My question would be, I know in our region, some of the ambulance crews use the Avisio and, you know, the injectable or the IV. And so was that taken into account that, you know, other agencies might be using other things?
No.
Okay.
No, that was not.
Okay.
Hello, everyone. This is Heidi with the One Program again. I just wanted to let you know that our number of One Program pharmacies has tripled in the last 4 months. And so you may see a lot of pharmacies in your area that are now One Program pharmacies. And we have connected each and every one of them to their local public health unit. Our pharmacies are noting that if the patient has to pay out of pocket for the naloxone, they're oftentimes refusing it. So it's been extremely valuable to have those pharmacies connected with the local public health unit to supply a stock of free Narcan for them to distribute in the pharmacy setting. So if you need me to let you know who your pharmacies are, please reach out to me. We've done the same to our pharmacies to reach out to you. But that, remember, those Narcan doses are going to those people who are qualified or who signify based on objective measures of misuse or overdose. So those are really the ones that we want to get Narcan in the hands of.
Thank you. And yes, like James said, this is a goal that, we would love to see, but reach out to us and, we can see how we can help too. I also wanted to include the 7 local public health units that are not receiving SOR funds. And these just might be potential gaps in naloxone distribution just because we don't fund them, so we don't necessarily know what's being distributed in that area. So we just wanted to point that out, that there are areas that are potential gaps. And then I also included the statewide total of naloxone kits that we're looking to distribute to really saturate the state. So back to kind of those optional strategies that some local public health units are hoping to implement and wanting to do in their area. So in relation to goal number 1 of prevention, we have 15 local public health units that are bringing awareness to the Parents Lead campaign, mainly through media and social media messaging and distributing kind of hard copies, brochures, things like that at community events and to local partners. We also have 16 local public health units bringing awareness to the Opioids Fill with Care campaign, again, through media, social media, messaging, and distributing information and education things. And then 18 local public health units are increasing the utilization of safe medication disposal practices. So this is including like your take back locations, so increasing those locations, promoting those locations, hosting or being a part of take back events, distributing doTERRA bags, and distributing DisposeRx products. In relation to harm reduction, we have 5 local public health units that are operating a syringe service program, and they're utilizing funds for just that operation of the program. We have 1 operating a mobile unit, and then they'll also be distributing naloxone and fentanyl test strips, whether that's purchased with their own SOR funds or purchased or provided through us at the state. We have 8 local public health units that are not operating a syringe service program, but are still using the funds in a harm reduction capacity, either contracting with a nearby syringe service program, promoting syringe service program services through messaging, decreasing that barrier of accessing syringe service programs through transportation, and then using that funds to see what operating a syringe service program in their area would look like and what are some potential barriers that needs to be addressed to operate one. In relation to improving access to evidence-based treatment, we have 13 local public health units that are using the funds to identify some barriers in their areas and how they can increase access for people to receive treatment. They're also reducing stigma through messaging, increasing access to treatment through transportation vouchers, supporting existing treatment services in the area, and then expanding or bringing new treatment providers to the area. And lastly, in relation to recovery support services, we have 13 public health units that are increasing access to peer support specialist services, whether that's right there in their own local public health unit agency or helping bring it to other providers or partners in the area, providing transportation to recovery services, providing for some childcare during recovery support services so individuals have that ability to access what they need, and then educating and reducing stigma through messaging. Kind of ends our as far as what community grantees are doing, but I'd love to open it up if there's anyone on the call that wants to talk about anything that they're doing or ask any questions related to the local public health unit implementation and what grantees are doing. If anybody has anything, certainly don't need to, but if anybody wants to. Okay. I will move on to the data collection and reimbursement information. So like we talked about, PIRE is our contracted evaluator. So they will again be doing the monthly reporting form. So those of you who have been receiving the funding and been a part of the grant in the past, you're very familiar with what a monthly reporting form is. But for those of you that are new, this will be great information to see. So it'll be very similar to the past. Forms are due by the 10th of each month, and it's really just gathering data on what you have been doing that month for implementing those strategies that you identified in your ITA. The first form, so October is over. We would plan to include any information and data from October in the November report. So October and November will be in one report and will be due by December 10th. And again, all forms are due by the 10th of the following month. PIRE will also be coordinating our GIPRA data collection. So for those of you who will be doing GIPRA collection, there is a little bit of a change. So after December 9th, a new GIPRA form will be utilized, but we'll be reaching out and working closely with those of you who are doing GIPRA collection to provide more information. So don't worry, this isn't all that we're going to be providing you. There'll be more to come for you specific individuals. So I wanted to point out just a few changes or just some kind of points that we really wanted to draw attention to on the monthly reporting form. We'll be requiring the report of how many naloxone kits have been distributed each month. And we wanted to point out that there is a difference in a couple questions. So we are wanting you to report naloxone kits that are distributed that you received from us. So when we send out some naloxone to you and then you distribute that, that will be answered in one question. And then the number of kits that you distribute that you purchased on your own with SOR funds are reported in a different section. So if you are a local public health unit that is purchasing some on your own, but also receiving some for us, you just might want to create a way to decipher which one's being distributed so that you're able to report that on a monthly reporting form. We also wanted to draw attention to the question of how many people were trained to provide school-based prevention and education activities to school-aged children. So this could be either you guys using the funds to train somebody else to go into a school to provide some training, or it can be if anybody in your agency is trained to go into the school or has been going into the school. So it's really just how many people were trained that month. The last question on this slide, how many people in your state entity were reached through outreach activities that targeted underserved or diverse populations? So these are those events or information that's directly targeting a underserved or diverse population. So it's not necessarily how many people from a underserved or diverse population that were reached through just kind of broad messaging. It's really that targeting, how many people were reached through a targeted activity. So if you have questions about some of these, feel free to always reach out and we can provide more clarification or even help with very specific kind of experiences or things that you guys have ran into, and we can help if you have specific things. A couple other things on the reporting form that we wanted to point out is that there's a question about entering the total number of clients served by medications for opioid use this month. So that's the number of individuals that actually received treatment from you guys for medications for opioid use disorder. There'll be a second section, a different section where you'll report the number of people that maybe you decreased that barrier to accessing treatment or helped them in some way to access treatment. So that's separate than this question. This is really just how many people are being served. And if you're entering numbers in this question, those individuals will need to have a GIPRA completed for them. So there is a little bit of difference between the people that you kind of helped access treatment and the people that actually you provided treatment to. Same goes for that second question of clients served by recovery support services. Again, it's not those individuals that you helped decrease that barrier to accessing it. It's those that you're reporting those that actually received that service from you. So again, any number of individuals entered in this section would need a GIPRA completed on them. And then lastly, one change is that local public health units that have been doing the home health program with the one program have been entering data into the monthly reporting form. So this will be different this upcoming period. You'll no longer enter it into your monthly reporting form. You'll just be entering it into REDCap, I believe. Heidi, I'm not super familiar with your reporting system, but I believe they'll be entering it into REDCap, and then the one program will just be gathering all that data on their end and reporting it in their monthly reporting form. So there won't be any duplication of reporting, and you won't have to report. I'm getting a thumbs up there. That's awesome. So I'm glad that's well received. Then as far as reimbursements go, very similar to how it's been in the past. For those of you that are familiar, if there's new grantees that are having any questions, feel free to reach out to me and I'd love to help you. The link to the form that you'll fill out, the SFN 1763, is listed here and will be provided to you guys to have. But it's the same if you've used it in the past, it's the same form. And again, those will be needed to be submitted by the 10th of the following month. So along with your monthly reporting form. Yeah, Karen, I see you have a question.
Just full of questions today.
I love it.
You mentioned that the first report is for October and November. Is the RFR the same? Do we do the RFR for the 2 months together in the December request for reimbursement?
So we're fine if you combine them for 2 months, and we're also okay if you submit the RFRs, one in November, one in December. That's fine. With us knowing that that first report will not be completed until December. Either way would be fine, as long as you can clearly articulate what the first reimbursement is for so that we can track that clearly. Do you agree, Amy, or would you rather they break them apart?
Yeah, I think I'm good with either one. I did want to point out that the contracts are still being processed. So those haven't been sent to you guys yet for signatures. As far as I know, they haven't been. So just know that you can submit for reimbursement and know that those contracts are on the way. So yeah, like I'm good with either way, just as long as you clearly identify, is it combined on one, or it'll be, clear if you've separated them. But yeah, I'm good with either way.
Okay, thanks.
Yeah, and those RFRs do say what is the billing period, so you can indicate if you're doing October 1 to October 31st and breaking them apart, or if you're going to do October 1 to November 30th, just as long as you have that clearly identified on the RFR. And like Amy said, those contracts are still going to be coming out to your agencies for signature, so we actually can't process the RFRs until we have the fully executed contract. So hopefully that timing will play out really well, but just a heads up that if you submit an RFR next week, we might have to hold off on reimbursing an extra week or so until the contracts are executed.
Okay,
but
that's
all
what
of the
I was asking, yeah.
Okay, and then all of the contracts are going to be dated to start on October 1st. So they will have an October 1st start date. So even though you don't have the contract in hand yet, all of October is reimbursable.
So SAMHSA has included some funding restrictions, so I just wanted to go over that information quickly here for you guys to be aware of. A lot of it has been similar to past restrictions. So funds cannot be used in addition to other funds. You can't have services that are supported through other accessible sources of funding. So if you are receiving these other grants, they should be used first. Then funds cannot be expended through the grant or subaward by any agency that would deny any eligible client, patient, or individual access to the program because of their use of an FDA-approved medication. So a medication for opioid use disorder, also known as MAT, medication-assisted treatment. So individuals that are accessing that need to be able to access all of the grant-funded activities. Funds cannot be utilized for treatment or recovery services for individuals who do not have a history or current use of opioids or stimulant misuse. So it's really for that population of individuals using or history of use with opioids or stimulants. Funds cannot be used to procure data waiver training, and that's because that's offered free of charge from SAMHSA, and there's a website there if any providers are interested in accessing that training. They can't be used to provide incentives to a healthcare professional to receive that data waiver training. They can't be utilized for treatment of marijuana. They can't pay for promotional items, can't be used to purchase or construct any building or structure for the program, can't be used to supplant current funding of existing activities. So supplanting is replacing funding of a existing program with funds from a federal grant. So grant funds can be used to support but not supplant. And then the last bullet is regarding contingency management. So clients may not receive contingencies totaling more than $75 for the budget period. Funds can't be used to make direct payments to individuals to enter treatment or to continue participation in prevention or treatment services. Can't be used for meals, although there is the potential for light snacks not to exceed $3 per person. Funds can't be used to purchase sterile needles or syringes. Oh, and that's the end. That's the end of the funding restrictions, I guess. So we're getting towards the end of our presentation here, and the last part is really just providing some resources for you guys. These are mainly just links to our website that have a lot of further links and further resources, and there's a ton of information that's accessible. I really just encourage you to reach out with needs though. Our team members would love to help provide any training and technical assistance that you guys need. So feel free to reach out when you have questions, if you need anything. Know these links are here for you to explore and access as needed, but we'd love to help too. So that's what we have for you guys today. Are there any further questions? I know we've addressed some throughout the presentation, but would love to answer anything else that you guys have for us.
Yeah,
Karen.
It looks. Oh,
sorry, James. Go for it, Karen.
I do have a question. You know, when you were talking about peer supports for crisis teams and emergency rooms, the question I have is, I understand that all human service centers now have crisis teams, correct? And so my question is, do you know, are each of the human services attempting to get a peer support person on their crisis team who would be able to be going into emergency room departments to assist in these, you know, people being seen there?
Yeah, so Karen, just to answer your question, so all of the regions are either have hired or are looking to hire peer supports to be integrated into their crisis teams. The way that that has played out from region to region is so different that I would say I would not expect that they would have that peer support integrating into local emergency departments. I would say it's more focused on Some of them are in their open access settings, some of them are in their CRUs, and some of them, actually, I don't think any of them are integrated into the mobile crisis teams, but it really has been very different from region to region. So I would say having peer support in an emergency department would need to be a separate initiative.
Okay.
And then I just want to quickly, a couple things in the chat. There was a question on is there training for school-based prevention and education activities? And then Heidi did put a couple of links in the chat, and I think that is something we could provide when we email out this PowerPoint to all of you. We could also include those links. There also is a question about are there protocols and procedures already in place for a leave behind Narcan program? That's something that I think we'd have to dive into and try to find some kind of template that we could share with you all. But that's a great question as well. Oh, and then it looks like, Michael, you have your hand up.
Has there been any talk of the Behavioral Health Division starting to purchase IM naloxone?
We have had some questions about that. The vendor that we currently utilize does not sell the intramuscular and injectable naloxone. So if that's something that would be a benefit, if there's big enough orders, we could look a little more into that. I guess we haven't dug into that very deeply at this point.
And it's mostly just because when I report out our naloxone numbers, I combine together IM and nasal, and so it'd just be easier mostly for reporting. But it costs $6 a dose for us right now. It's come down a lot in price, so it's not a huge burden on the budget. But if there's other people that need it and have trouble getting it, I'd appreciate the opportunity to get it from you too. So.
Great. No, thank you for that input. And then it looks like Sue. I think you're muted, or we either can't hear you. Okay, maybe we'll jump to Holly, and Sue, you could either, if you can get it fixed or type your question in the chat, but we'll circle back to you after Holly's question.
Well, I was visiting with law enforcement the other day, and they were asking me about, so apparently in the Minot PD, some of the money that they got from the opioid settlement, it was like $6,000 a year or something, but they're looking at adding some like medication drop boxes in different places.
But I didn't print them out like how Mike does. I have to add more info. But that's where I got 10.
Sorry, I had to mute somebody, but go ahead.
So we were having a discussion because we're planning on getting one put in our facility, but I'm wondering if anybody has purchased those medication drop boxes, and we're wondering if there's an option to have it outdoors instead of inside so that people can drop it off 24 hours a day. Does anybody have any experience with that?
I might let James answer this one. As far as the medication drop box being outside versus in your local public health unit, is that what I'm hearing, Holly?
Right. I think either way you're going to have it, attached permanently, but
yeah,
we just wanted to see what options we had to make the best, to make it most accessible for people.
Yeah, and maybe, you know, with that, we can check with, maybe send out a questionnaire to the other grantees to see if anyone has had experience in buying those drop boxes, and what they have found as some of those different options. So I think we'd have to follow back up on that, Holly. But great question.
Yeah, I mean, we have a Sharps drop box outside, and it gets utilized a lot. So we're thinking like a partner to that would be good, but we didn't want to spend all that money if there's things we should know ahead of time.
Yeah, definitely understand that.
We'll get back to you on that, Holly, okay?
Okay, thank you.
And then I see, okay, Sue's question. I'm doing a statewide training for ND League of Cities, November 16th. It is virtual. Can I refer the individuals to their local public health unit? And would that be for Narcan, Sue? Narcan training? Yes. Okay. Yes, you definitely can. I think that would be a great, in our messaging, we generally let people know that they can obtain Narcan either from a link on our behavioral health division website, their local public health unit, or their pharmacy, their local pharmacy. So we generally, when we do any kind of opioid messaging or presentations, those are the access points that we will provide where to obtain Narcan. So just to let you know what our messaging is, but that would be great if you would say contact your local public health unit. Great.
All right, well, I see we've kind of ended our time here, so I don't want to keep anybody too much longer. If you have other questions, feel free to reach out to me. We'd be happy to help, and I hope you guys have a good rest of your day. And oh, yeah, Michael, go for it.
I just added in the chat, one other spot to get naloxone is I became the state affiliate for Next Distro in North Dakota. So Next Distro is a nationwide naloxone distribution program. And so that would be another spot for individuals to get naloxone. And I've filled orders throughout the entire state of North Dakota in the month and a half that we've been doing it. But if you go to that website, it provides the training and everything there. And then when you actually request a naloxone, then it goes into a Google Doc that comes to me, and then I just mail it out.
Okay, thanks for sharing that, Michael. That's a good resource for everyone to have. Another opportunity for people to access naloxone. So that's always great. We love options.
Amy, this is Jordan. I had a question.
Yeah.
Are we still going to do like, I don't know if it was quarterly or every other month check-ins throughout the grant period?
Good question. Yes, so I do plan to do a quarterly meeting, again, like we had done in the past. So I'll be sending kind of out a scheduled set of meetings and give you more of an advance than some of these kind of startup meetings have had. So yes, that answer is we do plan to do quarterly meetings with all grantees again. Yep.
Okay, thank you.
Yeah, thanks for bringing that up.
And please feel free to reach out if there's anything you need before a next meeting or before we initiate any contact with you. Feel free to contact us if there's questions or things that you need assistance with.
All right, well, I think that concludes our meeting. So I hope everyone has a really good day, and look forward to just continuing to work with you and all the great things that are happening in North Dakota. It's really, really fun to see. So appreciate it, and we'll talk to everybody later.
Thank you.
Thanks.
Bye.